Your patient is 8 hours post-op from a subdural hematoma evacuation. Suddenly, they're thrashing in bed, pulling at their sheets, and becoming highly agitated. Do you draw up a sedative to calm them down so they can rest? Or do you call a code? I'm an ICU nurse and educator. My goal is to bridge textbook theory with the reality of what happens right at the bedside. While the free blood from a cranial hemorrhage requires attention, the ultimate threat to a patient's life is the invisible, relentless buildup of pressure inside the skull. If we misinterpret that early agitation as normal human annoyance or post-op pain, we allow a fatal mechanical failure in the brain to progress untapped. Let's look at why that happens. Head trauma causes 2 types of bleeds. Epidural hematomas are arterial tears that bleed fast. Subdural hematomas are venous tears, causing slower pooling bleeds. Both cause increased intracranial pressure, or ICP. As blood pools, it pushes inward against healthy brain tissue. The skull is a rigid, closed box. The brain gets physically compressed, pinching off blood vessels and starving tissue of oxygen. This hypoxia triggers the earliest physiological warning sign, an altered level of consciousness. At the bedside, an altered level of consciousness doesn't always look like someone falling into a coma. Early on, it looks behavioral. Your patient gets restless, they get irritable, they develop unexplained agitation. You will also see 2 early physical signs: a constant worsening headache and sudden projectile vomiting without any prior nausea. Because these early indicators are purely behavioral and easily masked by pain or stress, you have to maintain high clinical suspicion. If you miss them, the mechanical failure accelerates. When the pressure overcomes the body's compensatory mechanisms, the brain takes the path of least resistance. It is forced downward, physically crushing the brainstem at the base of the skull. This is called herniation. As the brainstem compresses, the body triggers a desperate late-stage reflex known as Cushing's triad. It consists of 3 specific vital sign changes. First, systolic hypertension with a widening pulse pressure. The top blood pressure number shoots up to force blood into the starving brain, while the bottom number stays the same or drops. Second, bradycardia. As the pressure builds, the compensatory mechanisms fail and the heart rate plummets. Third, irregular respirations. The breathing pattern becomes erratic, typically presenting as Shane-Stokes respirations, alternating periods of fast, slow, and completely absent breathing. At this stage, ocular signs emerge. Pupils become fixed and dilated, sometimes blowing up to 8 millimeters. The patient will also lose their doll's eyes reflex, meaning their eyes remain fixed straight ahead when you turn their head. You will also see abnormal motor posturing. Decorticate posturing is when the arms flex tightly inward to the core. Decerebrate posturing is worse. The arms rigidly extend straight out, indicating the damage has reached deep into the brainstem. If you see Cushing's triad or abnormal posturing, the brain is actively herniating. Without immediate emergency intervention, death is imminent. Let's go back to our agitated post-op patient. Giving a sedative masks their neurological decline. The correct action is to immediately treat for increased ICP. The first physical intervention is to use gravity. Elevate the head of the bed exactly 30 degrees to promote venous drainage. At the same time, keep the neck perfectly midline. Avoid flexion or bending, which can trap fluid inside the skull. Pharmacologically, you need to prepare an osmotic diuretic like IV mannitol. This medication pulls excess fluid out of the swollen brain tissue and shifts it into the blood vessels to be excreted. Concurrently, prepare the patient for an emergency CT scan or a neurosurgical evacuation to manually remove the clot and relieve the pressure. Let's recap. First, subdural hematomas are insidious, slow-pooling venous bleeds. Second, agitation and an altered level of consciousness are your vital early warnings that pressure inside the skull is rising. Third, Cushing's triad, systolic hypertension, bradycardia, and irregular breathing is the deadly late sign that the brainstem is being crushed. Identifying these behavioral cues as mechanical warnings allows you to intervene while the damage is still reversible. It is the hallmark of advanced clinical judgment. Hey, thanks for watching my YouTube channel. Don't forget to like and subscribe and leave a comment. Let me know what topics you want to see more of and how I can help you become the super nurse you were born to be. I hope to see you here again real soon.